Hello everyone, I'm Anitha Kammili from McGill University. I will be presenting about transitioning from open to minimally invasive en bloc esophagectomy to show that this can be achieved without compromising surgical quality. All of our authors do not have any conflicts of interest or financial ties to disclose. So, what is en bloc esophagectomy? This refers to the skeletonization of the esophagus and its corresponding lymph nodes from pleura to pleura, aorta to mediastinum, and this has been shown to result in a higher lymph node retrieval compared to standard esophagectomy. And this is important because lymph node yield is associated with improved survival. Also, minimally invasive esophagectomy has been associated with improved short-term outcomes. The study compared en bloc and standard esophagectomies to show that the survival is higher when the resection is performed en bloc. Also, some studies have shown that the lymph node yield using the minimally invasive approach is lower compared to the open approach. However, we do not know if this is a result of the approach itself, as in whether it's minimally invasive or open, or if some centers performed more standard or en bloc esophagectomies, for example. So the aim of our study was to determine if an established approach to open en bloc resection can be safely transferred to the minimally invasive approach using lymph node yield as a quality benchmark. To do this, we evaluated esophagectomies that were performed by a single surgeon with formal minimally invasive fellowship training. And then open en bloc esophagectomy was established over 5 years, well over 300 cases. And then the minimally invasive approach was introduced slowly in 2010 after becoming familiar with other complex minimally invasive procedures, such as maxillophectomy and laparoscopic gastrectomy, hiatal surgery, and so on. Now, how do we figure out or define if the lymph node yield you receive is sufficient or not? So we use the American Joint Committee of Cancer's 8th edition, and these guidelines were developed in collaboration with the Union for International Cancer Control. And they decided that for T1 cancers, we need to obtain 10 or more lymph nodes, for T2, 20 or more lymph nodes, and for T3, T4 cancers, greater than 30 lymph nodes. So we did an observational study over a decade from 2010 to 2019 and evaluated patient and tumor characteristics, operative details, and complications. In terms of statistical analysis, we used CUSUM analysis, Manuit, NIU, and chi-score tests. So there were a total of 508 esophagectomies performed over a decade. We excluded 3-field and left thoracoabdominal approaches, along with non-curative intent surgeries. This resulted in 269 curative intent en bloc Irish-Lewis or McEwen esophagectomies over 10 years. Our patient characteristics were well balanced among both groups in terms of age, sex, BMI, and comorbidities. And the tumors were more often located in the gastroesophageal junction. And both groups had predominance of adenocarcinoma histology. Also, the open approach was opted for more advanced tumors, and patients in this group were also more likely to receive neoadjuvant therapy, predominantly chemotherapy, prior to their surgery. In addition, minimally invasive surgery took longer. However, it has been associated with lower blood loss and a shorter length of stay, and the complications were similar among both groups. In the open approach, tumors were larger, and the pathological stage was also greater for patients in the open group compared to the minimally invasive group, and rates of R0 resection were similar among both groups. In terms of lymph node yield, the open approach did result in a greater lymph node yield. However, more importantly, the failures, which we defined based on the AJCC criteria, were similar between both groups, along with the median number of lymph nodes or lymph node shortage. In terms of long-term survival, both disease-free and overall survival were similar between the open and minimally invasive approach when they were both performed en bloc for both early stage and locally advanced cancers. In terms of the learning curve, we did a CUSUM control chart, which shows the cases for each group. So this curve shows the minimally invasive group sequentially, and every inflection point in the graph is associated with a failure, which was defined as less than 10 for T1 cancers, less than 20 for T2, less than 30 for T3, T4 cancers. And there are 13 failures. It distributed intermittently over the study period, indicating that there's no learning effect. Similarly, in the open approach, you can see that the failures are distributed intermittently. We also compared some other quality benchmarks. The number of procedures, for example. The proportion of esophagectomies performed every year, as you can see, the minimally invasive approach numbers are greater more recently. And we compared other quality metrics. As you can see, the complications are similar between both groups over time, and so are the rates of anastomotic leaks over time, and the rates of R0 resection over time are also similar between groups. And finally, the duration of surgery, which is another metric that can be used to determine a learning curve, is similar between both groups over time. So in summary, we can say that patient characteristics and outcomes were similar between both groups. However, larger, higher stage tumors were more likely to be selected for the open resection. And both groups resulted in adequate lymph node yield when the resection was performed en bloc. And even though there were 13 failures in the learning curve for minimally invasive approach, these were intermittent and in similar rates when compared to the open approach. The limitations of this study include that it's retrospective in nature, so we were not able to confirm if a lymph node shortage of 1 or 2, for example, was a result of the pathologist maybe not counting a little bit more, and some lymph nodes were resected. The pathology report said some lymph nodes were bisected, and they didn't include them in the final count. So our shortage isn't necessarily a true shortage. And this is a single surgeon, single center study, which means that it's not necessarily generalizable to the whole population. However, we do include a sizable number of cases to show that this can be done safely. In conclusion, an established open approach to en bloc esophagectomy can be safely transferred to the minimally invasive approach when this is performed by a surgeon with formal minimally invasive surgery training. I would like to thank our entire healthcare team for assisting with the study. And yeah, thank you for paying attention.